Can you hear me? Is this good? All right. I'm so happy to be here this morning. Thank you all and Karen for inviting me back, for having me. It really is an honor to be able to share this space with you guys this morning. So I was asked to come here today to talk about the intersection of reproductive justice and particularly clinical care. And you heard in the introduction that I'm an obstetrician and gynecologist, and I have subspecialty training in family planning. And so I spend a lot of time laser focused on reproductive health in my work. And much of this work occurs in the abortion space. And so I'm often asked to talk about that part of my work. In the past, much of the emphasis was on the technical and procedural parts of my work, right? So how is an abortion done? What medications or instruments are used? How do we treat and prevent complications? But more frequently now, I'm asked to talk about the other parts of my work. Things a little less procedural, more abstract maybe, but I think equally as important. And that's what I think I'm charged to do today, and I will. But first, I'm going to tell you a story. And now I have to admit that I've never been very good at telling a short story, so you have to bear with me a little bit. And this story is about how I got here. Standing in front of you this morning, my story. And although I can remember being a medical student like the folks here at the med school at University of Buffalo, my journey towards a career in medicine started way before I got to medical school. See, I always wanted to be a doctor. In fact, I can't remember ever wanting to be anything else. And I was one of those really obnoxious kids that walked around with the fake stethoscope and the doctor's bag. And I pretended to perform surgery and draw blood. I would diagnose friends and family, anybody really who came close enough or sat still long enough with all kinds of imaginary diseases and illnesses. I dispensed often unsolicited medical advice for diseases real and imagined. And I gave out medication in the form of Tic Tacs. And I was and still am the undefeated champion of operations in our house. I don't really know where this came from. I didn't grow up in a family of physicians. I didn't really know any doctors growing up other than my pediatrician that I saw annually for my checkup. But I knew that this was what I was supposed to be. I could feel it. I remember when I was applying to medical school and people would always ask, what are you going to do if you don't get in? What's your plan B? And to be honest with you, I never really considered not getting in. See, I didn't have a plan B. This was it. This was what I was supposed to be. I grew up in Washington, D.C., the seat of our federal government, the home of the President of these United States. Somebody sighed. Washington, D.C. is my touchstone. It's my point of reference. It's my home. People come from far and wide to see the city I grew up in. They often leave learning a lot about the country we live in and about my city. But one thing a lot of people don't know about Washington, D.C., something you won't learn on those hop-on, hop-off bus tours, is that Washington, D.C. is also home to one of the greatest income disparities of any city in the United States, where the top 10% of earners make 6 times more than the bottom 10%. A city with some of the greatest pockets of poverty of any place in the United States. And these income disparities are reflected in our communities with poor health outcomes and high rates of unemployment, with disproportionate levels of violence and over-policing. Our maternal mortality rate is twice the national average, and our HIV rate is 3 times the CDC's definition of an epidemic. Growing up in Washington, D.C. and bearing witness to this shaped me as an individual and as a physician that I would become. Now, I grew up in Washington, D.C., but my family is not from there originally. My family's roots are planted firmly in the South, where the vestige of segregation continues to cast its shadow far and wide. Stories of what it was like to grow up in the Jim Crow South live in my family's recent memory. They're told and retold by those who experienced it. The legacy of Black bodies that were bought and sold, consumed and disposed of looms large in my childhood memories. The people who survived were living testimonies of how and what the world thought of us. A recognition of the callous disdain with which this country treats people like me was not just a fable or a story talked about in school during Black History Month. It was a lesson passed on to ensure the survival of the next generation, our birthright. This knowledge of the way the world works shaped my family, and it shaped me. It influenced the way that I was taught to walk and talk and view the world and my place in it. It demanded an understanding that the playing field is not level. There are opportunities I wouldn't have, privileges I would not be afforded because of what I look like, not because of who I am or what I could do. Everyone doesn't get the same shot. And no, this is not fair. It reinforced the reality that we must work twice as hard to get half as much. A familiar phrase echoed throughout many Black households in this country and made popular by an episode of Scandal. I don't have to tell you that the road was not an easy one, but here I am, the doctor I always knew I would be. And as I continued my journey out of Washington, D.C., to Philadelphia for residency and to Baltimore for fellowship, and back home to D.C. where I live and practice now, I carried all of these lessons with me. Now, I do realize I wasn't asked to come here today to talk about myself. I was asked to talk about the physician's role in reproductive justice. But I start with my story because it directly influences my work. I bring every part of myself to the work that I do. My story, my history, my legacy, my experiences, it follows me. It follows me into exam rooms and into encounters with patients. It hangs and it hovers. It colors, and some days it consumes. It impacts the way I move through the world. It does this for me, and it does this for my patients. Their history, their legacy, their circumstances and lived experiences, their story impacts the way that they interact with me in that moment and the healthcare system more broadly. It influences their willingness to follow my recommended medical advice. It affects the likelihood that they will disclose risk-taking behaviors. It shapes the way that they perceive the patient-provider relationship and the way that they understand my place in it. When we talk about what it means to be a physician operating within the reproductive justice framework, what part physicians can play in advancing reproductive justice, it means understanding that abortion and pregnancy and contraception happen like everything else within the context of this individual's life. And so when physicians and public health agents and activists and advocates seek solutions, these solutions have to be grounded in this context as well. But to understand this context, we have to create spaces We have to create opportunities for our patients to bring their whole selves into the room. And this can be tricky because it only happens if we stop talking long enough to listen. In medical school, like many students, I learned a lot about a lot of things. And whether you remember it all by the end is debatable. But one thing we learned how to do really well is to talk. We talk about how to identify and analyze diseases, how to diagnose and treat disorders. We run through lists of differential diagnoses and we talk about treatment plans. We talk and we talk and we talk. The problem with spending so much time talking is that more often than not, you miss an opportunity to listen. It took me a long time to learn how to listen. To listen and to actually hear the person in front of me in that moment. Now, in my career, I've taught a lot of trainees, from advanced practice clinicians like nurse practitioners and midwives, to medical students and residents and fellows. And I think that as physicians, we are by far the worst at this listening. And as someone who trained in the traditional practice of medicine, I have to work every day to get better at it. Some days I get it right, and some days I miss the mark completely. Each day, though, I try to remember to work hard at listening to the stories that my patients tell. What brought them to see me that day, how easy or difficult it was to make the decision to have an abortion, why they are angry or sad or relieved. Sometimes I'm the only one that knows they're there in that clinic that day. Sometimes I'm the only one who will ever know, who will ever hear their stories. And so I listen. I listen to their stories, and if they ask, I tell them mine. I tell them why I'm there. I tell them what this work is like for me, why it's an honor to take care of them, how this is the best part of my work. But I'll admit that this listening is not always easy. Sometimes in these moments, listening to the stories that my patients tell is difficult for me. More difficult for the person who lived through them. But I listen and I learn. I learned how to ask, how do you feel? I learned to hear, I am nervous, I'm afraid. I learned to respond, you are strong, you are safe, you are not alone. In that space, I learned to listen to the stories my patients tell, to give them space to be sad or relieved or angry or silent. And if you'll indulge me, I'm going to tell you two stories. The first story is about a patient I took care of not so long ago, a 13-year-old girl named Maria. She came into our health center with her mom, and during the discussion with one of our health center counselors, Maria revealed that she was pregnant, and her pregnancy was the result of a rape perpetrated by a family friend. This person, who her family trusted, came into their home, befriended her family, and assaulted her. She came to our health center that day for an abortion. She didn't want to press charges because of her family's immigration status. They were undocumented. And she was afraid that she would be separated from them and they would be deported if there was an investigation during the prosecution and the pursuit of her rapist. She was 13 years old. She was afraid. She felt alone. The second story is about a patient named Allison. She was an addict who had been struggling with addiction on and off for many years. She was 34 years old when we met. She had 2 other children who were currently being cared for by family members. She desperately wanted to get clean, but couldn't qualify for admission into any rehab facility while she was still pregnant. For her, this abortion was what she saw as her last and final chance at getting clean and mending the devastation that drugs and addiction had wreaked on her family and the lives of her children. She was brought to us in shackles, flanked by 2 armed guards from the local jail where she was currently being held on drug charges for her abortion. In the years she had spent on and off the street, she had lived through and witnessed unimaginable things. But that day, in our office, when we met, she was also afraid. She also felt alone. These 2 people, seemingly so different, but in many ways the same, each deserving of all the compassion and dignity that would be afforded to any of us at a difficult time in our lives. These 2 women who sat across from me and told me their stories are just 2 women. 2 out of the thousands of women I care for each year. Not all stories are sad. Not all people are troubled. Not all patients are victims. These are just 2 stories. As an abortion provider, I have the privilege of being a compassionate witness to the stories that my patients tell every day. They tell the stories of the complexities of their lives. And life is complex. It's complex and it's intersectional. You should not enter into any conversation in the reproductive rights space these days and not hear the term intersectionality. Coined by scholar and critical race theorist Kimberly Crenshaw in 1989, it's grounded in the notion that our identities are not separate, just as our oppressions are not. These multiple layers of our identity combine to create unique experiences in our lives, and more importantly, unique oppressive existences for the individual. And as was stated in the Combahee River Collective's Black Feminist Statement in 1978, it is the synthesis of these oppressions that create the conditions of our lives. The reproductive justice framework highlights the concept that oppressions that people of color and immigrants and low-income folks and trans folks experience is not just additive, it's often multiplicative. They intersect and combine to create a perfect storm of oppression, injustice, and inequality. It looks like inadequate access to quality health care in communities of color. It plays out in bans on abortion coverage for low-income patients, like the Hyde Amendment. It looks like targeted, long-acting, reversible contraceptive promotion in communities of color. Despite the intersectionality of our lives, we operate within a health framework that urges us to collapse individual identities into neat boxes for our own ease, comfort, and simplification. This results in separate and unequal care. The reality is that these struggles are linked. Disconnecting the fight for reproductive rights from the fight for civil rights and economic justice will not allow us to impact outcomes in a meaningful and sustainable way. Think back to Maria and Allison. They weren't simply dealing with unintended or unwanted pregnancies. They were dealing with unwanted pregnancies in the context of so many competing and complex issues. Immigration, incarceration, poverty. These issues are complex, no doubt, but so are the lives of the people we care for. And so it's our job to ensure that conversations we are having around abortion and contraception and unintended pregnancy remain complex as well. Understanding that the overlapping identities that many people face, multiplied by converging and competing oppressions, manifest in ways that continue to perpetuate unequal access, underrepresentation, and maintenance of the status quo. We must make room for these complexities in our work and introduce them into every conversation that we're having in reproductive health and rights spaces. How do we do this? What does it mean for our role as healthcare providers? How do we translate these theories into actionable items? There's no clear roadmap. But since I'm standing here and they gave me a mic, I'm going to make some suggestions. First and foremost, particularly for those of us who operate in the clinical space, who provide clinical care, as we enter into our patient encounters, I want to invite us to make room for the other person in the room, the patient. I teach students, and I talk about this a lot. We train a lot of ego into our healthcare providers. We're taught to see ourselves as the experts in every room. The problem here is that there's not enough space in the room for you, your ego, and the patient. If you check your ego at the door, you can make sure that there's enough space for someone else to actually be present and completely there. This means you must allow this patient to be the expert in their own lives. This doesn't mean you don't have some medical expertise here, just not when it comes to what's happening in their life. It means providing reproductive health care in the context of this person's life and this person's lived experience. It means asking ourselves, in what way are we complicit in contributing to barriers that make it difficult for this person to access and receive care? Sexual and reproductive health care cannot be fully understood outside of the political and social and racial context in which we live in this country. Let's start by seeing this, acknowledging this, and considering the implications that it has in the care we provide. Secondly, for those of us steeped in the reproductive rights movement, I would challenge us to move away from choice-based activism. So many of us in this movement have spent our time and our energy and our resources focused on preventing the overturn of Roe. And don't get me wrong, this is an important issue, but the right to choose means nothing if you can't access the resources needed to even make it to the clinic to exercise that choice. If you can't raise the children you already have in environments that are safe and feed them food that is healthy and send them to a school that isn't failing them. When systemic inequity is our platform, focusing exclusively on choice is fundamentally disrespectful. It is grounded in the experience of the privileged and ignores the competing priorities that other communities and other individuals have. So it's not enough to focus our energy on choice. We need to ask ourselves, who gets to choose and who doesn't? All choices are not equal. They are not judged equally. They are not experienced equally. The individual is robbed of their agency and autonomy if the choices presented are so narrowly focused that they don't even feel like a choice at all. We must recognize that in our current society, this choice, this opportunity to be in charge of your own body, the ability to control your own fertility, the power to choose, is a privilege. And it's not one afforded to all of us equally. When the term reproductive justice was coined by a group of Black women in 1994, this concept that places reproductive rights within a social justice framework deliberately left out the language of choice. These women, having recently returned from the International Conference on Population and Development in Cairo, where the international community identified reproductive rights as a human rights issue, met at the Illinois Pro-Choice Conference in Chicago. And while discussing their lives and communities in the context of the reproductive rights movement in the United States, these women saw that as Black women, they could relate to the lived experiences of communities around the world that were historically unable to access healthcare services and left out of discussions on reproductive healthcare more broadly. Given that the women who developed this framework represented communities that had few real choices, they instead integrated the concepts of reproductive rights, social justice, and human rights to coin the term reproductive justice. And a few years later, in 1997, the sister song, Women of Color Justice Collective, was formed by 16 women of color-led organizations with a focus on addressing the social, political, and economic inequalities that contribute to infringements on reproductive rights through grassroots mobilization and public policy action. This reproductive justice framework draws attention to the importance of changing structural inequalities that impact women's reproductive health care and their ability to control their reproductive lives. It is intentional, it is on purpose, and it happens outside of the health center. In order to make our work to advance reproductive health and rights meaningful and sustainable, we have to move outside the doctor's office in the form of advocacy and activism. The reproductive justice framework isn't just an exercise in intellectual discourse. This framework is a lens through which we must view all the work that we do. It must be operationalized and integrated into our systems and our structures. Doing abortions is not enough. Sitting in our academic ivory towers is not enough. We must use the privilege we have to affect change. Privilege and oppression are two sides of the same coin. The challenge is to recognize the privilege we have and understand how it manifests in our lives. Many of us in this room have power and privilege that few will ever know or experience. What will you do with it? Will you continue to participate in, promote, and perpetuate a two-tiered system of healthcare? One that's divided along economic lines, one that differs based on your socioeconomic status, your zip code, your race? This is not equity. This is not justice. This is not choice. For the most valuable of us, our healthcare systems perpetuate and highlight the existing inequity in our lives. Our systems serve to maintain the status quo of oppression, injustice, and abuse. They reinforce the dominant narrative that we can't be trusted to make decisions about our own bodies, our own lives. As individuals who often hold the most privilege in these spaces, we must work diligently and ceaselessly towards equity and justice by shifting the power dynamic back to the individual as much as possible, as often as possible. And this work is hard. Make no mistake, there is a lot of work to do here. But don't be dismayed, and more importantly, don't be distracted. Don't be distracted by the rhetoric. Don't be distracted by the tweets. Don't be comfortable in your positions of privilege. This is not a spectator sport. Get up, get out, and fight. Fight for the dangerous assaults on reproductive rights that don't begin or end with Roe. Fight the state level attempts at rolling back access to reproductive health care services for the most vulnerable of our patients. Fight the stigmatizing language that creates false dichotomies between us and them. Fight for the freedom of others, even when your freedom is not in jeopardy. And use whatever you have at your disposal to do so. In the coming years and months, under an administration that is focused on building barriers, literally and figuratively, alienating communities and dividing us all, we must be called upon to fight against what feels like worsening storms and rising waters. We will need to double down on our commitment to reproductive health and most especially reproductive justice, and draw upon our deepest belief that every person deserves an opportunity to decide what happens to their own bodies and to their own lives for themselves. And so I come back to the story, the first one that I told you in the beginning, my story, how I got here in front of you this morning. A wife, a daughter, a sister, a mother, a physician, a Black woman, a Washingtonian, an advocate, and an activist. In telling you my story, I'm also telling you the stories of the people I care for and care about in the community I serve, in the city I grew up in. Our stories are connected. They're inextricably intertwined. They are complex, and they are intersectional. As my time with you this morning comes to an end, I want to ask you to think about your own stories. What brought you here today? Why you chose to spend your day like this? Think about this moment, about this work toward equity and justice. There is a purposefulness in this work, and it's my honor to stand here before you, sharing my story in this moment. Thank you.
Thank you for that powerful and poignant talk. If there's any questions, please raise your hand and we'll begin our conversation. Dr. Perritt, can you talk about some of the activism that you're involved in now?
Sure. So my activism looks a lot of ways. I'm fortunate enough to live in a city where there is lots of work to be done, whether it's on a local level or a federal level. And because I live so close to the federal government, I have an opportunity to bring physician voices and patient voices to the policy work that I do a lot. You know, one of the reasons I decided to pursue a master's in public health is because I wanted to have a broader frame for which I provided the care. You know, in medical school, our training is very focused on the individual sitting in front of you, right? And sort of managing this disease or this illness in this person. And the public health lens gives you a broader scope, right? Population level change. And there's also this huge thread of policy that runs through it. And so it became pretty clear to me during the course of my education and training that all of these things had to go hand in hand, right? It's amazing to be able to impact individual outcomes. It's really spectacular to impact things at a public health level, but if you can't affect policy change, then how far can you go? And so my activism varies. It varies in terms of, you know, supporting bills and that are happening at a local level, but also talking about legislation like the 20-week abortion bans and any gestational age bans, mandatory reporting for minors. It also intersects with all kinds of grassroots and advocacy work that's being done regarding sexual and reproductive health, and particularly the impact that it has on young people and other traditionally marginalized communities. And so it's busy. And I see patients. I still see patients. I provide clinical care at Planned Parenthood in DC and Maryland, and I travel quite a bit, providing clinical care as well, and doing this work in lots of different ways.
Can you talk a bit about your consulting work and how that plays into this larger picture?
So the consulting work came about 2 years ago when I was the medical director at Planned Parenthood in DC for a number of years, and I wore a lot of different hats, right? And so there's an administrative role and there's a clinical role, and then because I have an interest in advocacy and grassroots work and policy work, I was doing all of that too, so I was doing like 6 jobs. And I had to think a little bit about where I wanted my energy directed. And I knew I wanted to continue to provide clinical care, but I also wanted to incorporate all of these other pieces that were so meaningful to me, particularly work around reproductive justice and racial justice. And so I decided to leave the position as the medical director at Planned Parenthood, although I continue, as I said, to provide care there, and focus on doing consulting. Because the question came to me, how can we do this work in a better way? We're not moving the needle on what we call reproductive health disparities, and a lot of that has to do with the fact that we are extremely reluctant to name racism as a primary cause of these disparities. And somebody has to say that out loud. So we hear a lot of statistics about Black women have higher this, Black people have this, communities have this, and we're suffering, right? And the supposition or the idea that's buried in those demographic descriptors is that race is the problem. And race is not the problem. Racism is the problem. That's why Black women have higher rates of maternal mortality. That's why communities of color have higher rates of STD, because we have higher rates of incarceration, and systemic racism has played a role in all of these things. And so as a consultant, coming back to what you actually asked me, and not sort of all of my rambling, but the reason why I started consulting is because I wanted to be able to bring the experience that I have as a clinical provider, as a Black woman who's lived in the community and done this work my whole life, into these conversations, and to say it's not enough to do research on discovering disparities, right? Let's talk about what we can do to address them. Let's bring these voices into the conversation and have us sitting at these tables. And me as a proxy for the communities that I represent, right? Because if I'm there representing communities that are impacted, then my presence there is a way to bring community leaders and activists and advocates to the table, right? I'm not there to speak for anybody's experiences, but it allows me to open the door so that we can have contributions that are happening at a community level, and that they have an opportunity to discuss whether it's the interventions or the outcomes measures or whatever we're doing in communities. They should have an opportunity to speak on those things as well. And so it's a way to merge the grassroots and the grass tops way that we're doing this work. Yes.
Thank you, that was a really wonderful talk. I was especially moved by what you said about reproductive justice being connected to the right to parent. And I was wondering if you could elaborate on, within the United States, some of the barriers that women encounter that are obstacles to parenting, and like what we might do or what you're working to do about that.
So it's really interesting because people really focus on the right not to parent, right? But the reproductive justice framework is this triad. So it includes the right to have children, as well as the right to not have children, and the right to parent your children in safe environments. And it's important that we don't leave those other two pieces out. And so the narrative that's been created around anyone who chooses abortion is that this is not a thoughtful decision, right? But we know that the majority of individuals who have abortions also have children. They know what it's like to parent already, and they're making these decisions in this context, right? And so when we look at the legislators and the activists who are working against access to abortion, these are often the same people who do not support social structures to help people parent, right? So elimination of Medicaid expansion to help cover prenatal care and obstetric care and postpartum care for individuals who have done exactly what you asked them to do and had this baby, right? And then have no structure in the community to be able to do so. We were talking on the way up about the school system in DC and how very segregated it is and has always been, right? And so what happens if when you have a child and you can't send them to schools that are being funded in any meaningful way, and you cannot educate and count on the school system to even educate your children, much less keep them safe, depending on the communities that you live in. So there are all of these structures that individuals are operating in that this attempt to move reproductive health out of those spaces and talk about them in isolation is nonsensical. Everything is absolutely connected to the way that we live and work and play and pray in our communities. And being able to put that back in that context is what this reproductive justice framework does. It says we cannot remove this piece. This happens in the context of people's lives, and we need support services like safe schools, like healthy food, like healthy neighborhoods, in order to be able to have complete and whole lives. And this is what everyone has a human right to do and to have.
I just want to thank you for your remarks, and I share a lot of the same views that a lot of these things go hand in hand, and that you have to address more than one problem at a time if you're going to solve the overall problem. But I do have a question. So I work for an assemblywoman, and as you point out, a lot of the opposition to things like pro-choice legislation is coming from people who take a very one-dimensional view of these things. And so they have a very one-dimensional view on, immigration, on, like you said, safe schools and healthy foods. And their rhetoric always goes back to, well, who's going to pay for this? The almighty taxpayer, which is, kind of dog whistle language in and of itself. So, what do you suggest for kind of getting around that? Because it's hard to work with people who refuse to see more than a one-dimensional picture. Well,
I think in the past, I probably would have said evidence, but evidence doesn't seem to matter that much anymore. But there's a lot of evidence that actually supports funding social service programs, saves money. And so the fiscal argument is not one that holds water when you actually look at the data, right? And family planning services are a really great example. So public funding for family planning services, for every dollar you spend, you save $8 in care for this individual, for unwanted pregnancies and prenatal care, sort of all of the things that go. So while I don't necessarily subscribe to sort of the fiscal argument for why we should be doing this, I think that there is an ethical and a moral obligation that we have to provide these services. But for those that are focused on that, there's really strong evidence to say that this argument does not hold water. This is a cost savings for society and for the individual, and particularly for the state. But it's hard to argue with someone who is so who is living in this huge gap between the reality and the rhetoric, right? Because this hyper focus on one view and the refusal to see other sides of it makes it difficult to reason in those kind of cases. There are a couple of other things that you can do besides presenting the evidence. One thing that works really well with legislators is voices of their constituents. And so organizations like Physicians for Reproductive Health coordinates physician advocacy in this way, and particularly physician advocacy at a state level, right? So mobilizing patients, mobilizing providers, particularly when the decisions that are being made are healthcare decisions, right? To go in and say, listen, I actually have a lot of degrees. Look at all the letters behind my name, and I take care of people, right? And I've committed myself and my profession to doing this work, and I actually know what I'm talking about, and bringing that voice and saying, I am Dr. Perritt, and I live in your district, and this is what matters to me as your constituent, and having whoever is there, but talking from the angle of a constituent seems to have a huge impact for places that get a vote. We don't in DC, so put that on the video, right? No taxation without representation. So without home rule, we're lost. But for those who live in a state that actually have voting power, that makes a huge difference, right? Bringing faces to it. We saw progress in the LGBTQ movement with this, right? Putting a face to the individual. And it's hard to do that in reproductive rights work. We're working at it with reproductive rights and immigration, right? To say, like, these aren't just numbers, these are actually people, and this is how we are affected, this is how we are impacted by this, and this matters.
Well, and I think, like you said, bringing a face to it, I think that's a unique challenge when it comes to reproductive justice,
Yes.
because there is such a stigma
Yes.
around having an abortion, or or being a mom who struggled, with raising your children, and so many of the other ideas that go along
The stigma is deep-seated and insidious.
Yeah.
And so this work that we have to do to push back on this stigma is an uphill battle. And so the Physicians for Reproductive Health Voices for Courage is one way that it's being done, for doctors coming out and saying, I'm an abortion provider, this is why I do this work, this is what's happening. Organizations like Advocates for Youth and their 1 in 3 campaign, as well as Shout Your Abortion, right? And so people that are coming out and saying, I had an abortion, repeating this statistic of 1 in 4 women having an abortion in their lifetime, it's much easier to other someone when you don't know them. But sharing stories is hugely impactful. But it's the difficulty, right, when you're talking about abortion, because of the shame and stigma that is tied to it. It's difficult, but not impossible. Yeah.
Thank you, Jamila, for such a wonderful, thoughtful presentation. I wanted to raise 2 themes that I think are implicit and perhaps explicit in what you said. And that is that once you create a reproductive justice category, you've taken the notions, you've taken it beyond what we conventionally see as rights, and you're really talking about redistribution in the United States based on certain categories and classifications. Including the fact that poor people, poor women, are usually seen as irresponsible and bad providers and losers, as thinkers about how to behave in a society. So the question of how one deals with the redistributive dimension, which is, I would argue, one of the deep dimensions of this whole discussion about reproductive justice. And then secondly, the problem at the state level of the confusion between medicine and politics. That is the legislation that is enacted, particularly by the states, and this is where the big problem comes. As a lawyer and as a law professor, I know that what's basically happening at the state level is that politicians are making medical judgments and medical decisions, enacting them into law, and the impact of those decisions reflect a political position which is to basically squeeze abortion out of, or pregnancy termination in any form out of the picture, minimize it. And that's connected then with a much deeper backlash of misogyny in this culture at this time, or the not that misogyny suddenly appeared, but the ways in which it was contained, and people, and particularly women who were feminists, hoped to contain it, and it's now exploded. So I wonder if you comment on, or have I got it right, or?
I agree. I think you're absolutely right, particularly when we're talking about the desire to eliminate abortion, period. That's what this is about.
Yeah.
And so it's couched in a lot of different ways. It's couched in questions about safety, right? That's the most popular one. We want to make it safe for women, and so we're going to enact all of these laws to make it safer. And it's not about safety, it's about control. It's about misogyny, it's about paternalism, and it is about institutional racism, because I assure you, they care not whether I have an abortion, right? This is about maintaining births among the fit and eliminating births among the unfit, right? And so, we think back to the history of reproductive rights abuses in this country, particularly the eugenics movement that was supported and sanctioned and funded by the government, right, for years and years, well into the 1970s in places like North Carolina and Mississippi and Alabama, and these things that we don't talk about. The concern is not whether or not I'm going to have an abortion, and there's not a desire for more babies that look like me. And so there are lots of things that play into all of these issues, particularly the desire to eliminate abortion access. And so we have to name that. We have to say, this is what it is that you're attempting to do. And I'm going to call it that, and let's move on from there, however you want to describe it. In terms of the explosion of misogyny, I think that you're right. It's something that's always been there. There's just more of a public forward-facing acceptance of it now because of the environment we live in. The same way that there's a greater acceptance and tolerant and forward-facing overt racism and homophobia and all of the things that we see, transphobia that has become elevated to this public level that has sort of ridden under the surface for many years, but is absolutely now the country seems to have developed a taste for in a public way. Yes, I think.
Thank you, Dr. Perritt. Setting policy aside, what can be done on a grassroots level to end maternal postpartum mortality?
Yes. So there are lots of people that have been working at this for a long time, people that have been doing birth equity work at a community level. And so I'm so glad that you brought in this grassroots piece, because it is absolutely imperative that we partner with people who are already working in the community. And we bring all of the funding and privilege that we have to that space. The problem is that, those of us who are in the ivory towers, we hog all of these resources, and those that are working at the grassroots level, or unless we come in and then do all of our research and then take the data and leave, right? Because that's the other way we intersect with those that are working at a grassroots level. But actually doing things like community-based participatory research in a real way, right? Not just on paper, but partnering with those that are working at a community level and finding out what's happening there and moving from there. I was work with this woman who runs a birth center in DC that is amazing, and she is doing this phenomenal work, right? With this, and it's full spectrum healthcare in this facility. It is one freestanding birth center. And the way that it's, yeah, absolutely. And so it's this amazing place that's providing care in a way that is completely comprehensive and holistic for this individual. And so there are lots of people, there are folks that are working on birth equity work. Black Mamas Matters does a lot of work on birth equity to particularly target disparities in maternal mortality and talking more about it. I think we saw a lot more conversations once Serena Williams' story came out about what her experience was postpartum, and so we're having more conversations around disparities in equity regarding maternal mortality. But there are people that are doing this at a grassroots level, and the key is not to recreate the wheel, because it's happening, and it's been happening in communities around the country for a long time. The trick is to be able to come and partner, right? To sit at the table, particularly as a listener, and finding out what's going on and figuring out ways that we can partner to support those that are working at a community level is going to be critical.
So, just, how you said that we have to be able to say racism has to be named as a cornerstone of the lack of reproductive justice, and I totally agree with that. And I think another place that we need to complicate our thinking about it is around disability justice. Yes. And reproductive justice from many different angles. Who's allowed to have children, who are not allowed to parent, how we talk about genetic testing, yes. Right to access to care, all the Medicaid cuts, what is that going to mean for people who are disabled or chronically ill, and a certain level of mistrust, again, between communities about when we talk about reproductive justice, who are we talking about? So I wonder what your perspective is on that.
Absolutely. There are lots of communities that are traditionally left out of conversations about reproductive rights. LGBTQ people and those in the disabled community we never talk about that when we're talking about reproductive health and rights. And sometimes the changes are as simple as changing the language in your forms, right? Our forms are so heteronormative and gender specific, particularly in abortion care, right? And not to say that all you have to do is change your forms. There's a lot of work that needs to be done, right? So don't misquote me in your tweet. But so there's a lot of work to be done with disability rights, with LGBTQ rights, both for abortion care, but also for parenting. These are the same issues. Whose children are being taken away from them? Who do we decide is fit to parent and who's not? So making sure that when we're looking at, although this framework was developed by Black women, the intersection of racism and sexism and oppression happens across all of these intersections. It's disability rights, it's gender rights, it's all of these things, absolutely, and all of those things should be and must be included in conversations when we're talking about reproductive justice.
And ableism.
Absolutely.
I think it's really, people don't get the concept. And, there's a lot of touchy things, including who's appropriate to abort.
Mm-hmm.
So
yes,
there-
absolutely.
yeah.
Absolutely, I agree.
This is just kind of speaking of grassroots stuff and whatnot. The Buffalo News is reporting that there was a transgender woman murdered on Tuesday, and so there's going to be a vigil that's the Transgender Health Initiative is in the process of planning. But the Buffalo News is just reporting it because they misgendered the person yesterday. So, the first reported homicide in Buffalo this year is a transgender woman.
And so what that
all over the news on Tuesday, but they didn't release any other information. And then yesterday they misgendered, and today they're reporting it was actually a trans woman.
And this is an opportunity, right? It's an opportunity to talk about all of those things, to talk about misgendering people and the impact that has, to talk about the murder of a trans person and what that means in the context. And it's important that everybody comes out to that, right? So we cannot isolate these issues. We can't say, well, this isn't about abortion care, so this is not our fight, right? And dividing these resources is not something that's really helping any of us. And so we have to come out and coalesce and support issues when anyone is in jeopardy. This is something that is critical. So thank you for saying that and for bringing that up. Yes.
Thank you. As everyone has said, it's such a wonderful talk. My question has to do with your unique vantage point. I wonder if we could take advantage of it a little bit by asking, as you survey the current landscape, political landscape, what advocacy efforts do you identify as being most effective? And what way forward do you see? I don't see a way forward. We have very entrenched positions, irreconcilable differences on this. Do you see any kind of way forward?
I think that it's hard to engage people really consistently on a political level, right? And so we sort of see these big swings, and some people argue that this is sort of part of it, right? This is the way the course of things go. We had Obama for 8 years, and then now we have a sweep of the 3 branches, and then we'll see a backlash in the other way, et cetera, et cetera. But I think that this is a unique opportunity to capitalize on the attention that's being paid to what's happening politically in a different way, right? People are much more engaged, and you can define engaged in any number of ways. For some people, being engaged is voting, right? Going out and voting in the elections. For some people, being engaged is protesting and marching. For some people, being engaged is letter writing. For some folks, it's actually just watching the news, right? Paying more attention. But I think that what we need is a strategy that's going to be able to engage people wherever they are and elevate the issues so it moves from just paying attention to actually acting on them. It's really hard, I think, to get communities that have a distrust of the political system more broadly engaged in the process and the value of going out and voting, right? Because if I don't tie my liberation to the voting booth because I can't count on you to do the right thing, then saying that engagement only counts when you vote is something that is a huge misconception. So I think working on ways, and this goes back to how we intersect with communities that are most impacted and affected, and ways to engage and translate this emotion into actionable items. It's not an easy one, In terms of a way forward, I think that, I don't know, I'm not by nature an optimist. you know. So I don't know the way forward. I hope that the impact of all of this rhetoric on the country at large will be one that's positive to move toward inclusivity. I don't know what the way forward is.
First, thank you as an advanced practice clinician in this world. I really am happy that you're here and bringing this kind of framework to our community. But I have a question kind of about something that's happening nationally that's definitely relevant here in Buffalo. Kind of the large-scale healthcare delivery systems being religiously based and the system being religiously based, and how we can kind of use this framework to address some of the barriers that that faces, especially in light of the recent expansion of the so-called conscious protection.
Yeah. I think that's something that's really flown under the radar for so long, the impact that the acquisition of hospital systems and health systems by religious organization has on the way that care is delivered. And so it's, one is naming it, right, saying that this is an issue and this is the way that it impacts care. Guttmacher did a lot of research about this, looking at what individuals know, particularly when they come in to deliver their baby or to come in with reproductive health concerns, about how their options are limited when they show up at a religiously based institution. And it absolutely impacts the decision-making process. There was a patient that I got called with a referral about, and it was something that was sort of what we call a curbside consult in medicine, right? So not like a formal consultation, but this is this patient, I have a question, I want to ask your opinion on it, sort of almost like maybe off the record kind of a question. And this was a patient who had been admitted to a Catholic hospital, who was pregnant at, later in the second trimester, and was having chest pain. And this is a person with a significant history of cardiac problems, who had delivered a baby a year before at that same hospital, and it was the fourth C-section that she was having. And for anyone who's done a C-section, the more you have, the more scar tissue you have, the more risk and complications. And wanted her tubes tied, but could not have a tubal ligation because she had that C-section at a Catholic hospital, right? And so she was back with an unwanted and unintended pregnancy. Now, to complicate the story even more, during that C-section, she had a heart attack. And so they coded her during the C-section, right? So lots of reasons why this person has significant medical problems and should not be pregnant. But her delivery at a Catholic institution meant that she could not have her tubes tied at that point, and now she was back with complications. The recommendation should have been to terminate this pregnancy, but again, she's at a Catholic institution, and so that was not something that was being discussed with her as an option, right? Not that this person at this Catholic institution had to terminate the pregnancy, but what are we discussing in terms of options for this individual? And so the call from my colleague was that I feel like this is absolute malpractice, right? This person should be counseled about all of the options, risk, benefits, and alternatives, regardless of where she presents for care. And she was presenting here because this was the place that took her insurance. And so there are lots of issues that are combined in this purchasing of hospital systems and health systems by Catholic institutions that are not limited exclusively to abortion. That reproductive health care more broadly is being impacted on a global scale by this.
I'd just like to point out that in Western New York, you don't have to go to a Catholic hospital to be denied an abortion. You can get an abortion in any hospital in Buffalo, New York,
Yes.
no matter what your health issue is.
And that's common in a lot of places, because the cost, and sometimes it's an absolute rule, sometimes it's an unwritten rule, and it says the hospital system will say we don't do elective abortions, which is a really loaded term in and of itself, right? So whether it's a hospital policy or an unwritten policy, or just cost, right? To have an abortion in a hospital, the cost is excessive. You're paying for the anesthesiologist, you're paying for the hospital staff, you're paying for the lights, you're paying for all of these things. So the cost for abortions at hospital systems has risen dramatically, and places like Planned Parenthood, for example, have kept the costs low, right? And so that's one of the benefits of having abortions done at an outside facility. But what happens if you're sick? What happens if you actually need an anesthesiologist? What happens if you prefer general anesthesia? Right? Those things are taken out of the pot in terms of options. So it's eliminated not just because of who owns the hospital sometimes, but because of all of the other systems that are structured to decide that this pregnancy termination is an elective procedure and something you don't need and doesn't matter.
So I don't know how big an issue this is. I'm guessing probably a pretty big one, but how big of an issue this is nationally. But I know an issue that we have here in Western New York is another thing that you run into is that if you find doctors when you're talking about permanent sterilization or abortion or whatever, you can have an OBGYN who is perfectly willing and progressive enough to want to do those things or be willing to do them and be trained to do them. But we run into the politics and the cost of where they have rights to, so which hospitals they have rights to. So for example, you could go, I have multiple friends who have actually had to change who their OBGYN was when they got pregnant because they wanted to be sterilized post-pregnancy, and their doctor, their longtime OBGYN, could only had rights to deliver at a particular hospital. And you get into the politics and the cost of being able to get other hospitals.
And reproductive health is the only thing that occurs that way, right? It's the only medical procedure that is impacted in that way. And there's a really great study done out of UCSF by Jody Steiner, who looked at residents who had been trained to do abortions, OBGYN residents who had abortions training, and said that after finishing this training, saying they had an explicit desire to practice in a place that allowed them to provide abortions, or they had a desire to provide abortions in their practice once they finished their training, followed up with them down the line, and the vast majority were not providing abortions. And the question was, why not? And it was because of these logistics, right? So they joined a practice or a hospital system or had colleagues who did not approve of, would not support, could not do abortions. And so all of the logistics that came around that meant that the number of providers, even though they had been trained, did not have the capability because of the logistics of their practice to be able to do it. And this conscious projection, I didn't talk about that, that was the other part of your question, is an important one. This idea that you can refuse to provide care to someone, and this being extended for lots of other reasons that are absolutely not related to the health of the individual in any way, is a really dangerous one. And for many of us who practice obstetrics and have done gynecology and provide abortions, we've seen this play out, this conscious ejection, as if those who provide abortions have no conscience, right? So let's go ahead and name that dynamic and why we're calling it a conscience on their side and none on ours. And this idea that this is something that I should be able to opt out of. When I was in medical school, I have this thing about vomit and saliva, like it creeps me out. And so I had to do, in medical school you have to do you have to rotate in everything. And so I had to do an anesthesiology rotation. And there's a lot of spit in anesthesia because of the tubes and all of that. It's awful. And I wanted to opt out of it. I was not allowed to opt out of it, no matter what. But if you say you don't want to participate in abortion care in any way, shape, or form, as a medical student, as a resident, as a nurse, as a medical assistant student, whatever way you want to opt out of it, if you don't even want to set foot in the Planned Parenthood during your OBGYN rotation, much less provide abortions, then that has to be honored. And this is the only practice that you are allowed to opt out of learning how to care for people. It's the only way.
So is that institutionalized misogyny, institutionalized Christian morality? What you know what I mean? Anyway, it's a
yes,
it's a rhetorical question.
All right.
Yeah.
Dr. Perritt will be with us for the rest of the day so we can continue conversations informally. But let's first, I want to let you know we're going to have a 15-minute break before we start the panel. There's coffee and snacks, but before we do, I want to thank Dr. Perritt for a fantastic